Okay, I think we're ready to start. Welcome to the second day of Ketamine 2021. My name is Rupert McShane, and I'd like to introduce my co-host, Sarah Costi, who will be chairing some of these sessions alongside me. We had a great day yesterday, lots of terrific discussion after some fabulous talks, and I'm sure today is not going to be different in those regards. There are a few housekeeping things to talk about. The first is that our first speaker is from China, and so Psyying Wang has sent us a presentation, and we'll need you to ask your questions by chat during that presentation. And the reason is that because we're unable to bring her in by Zoom from China, or indeed any other media, we'll email her the questions and get the answers in time for the discussion session later on this afternoon. So send in your questions during her talk, not afterwards. You'll remember that Paul Glue gave a great talk yesterday about anxiety disorders, and he has kindly answered by email all the questions that were asked, and so we'll deal with those during the Q&A session as well. The form of the Q&A session is actually going to be a bit different today, basically because one of our speakers has to leave early. And so what we thought we'd do instead of splitting the session is just to have everybody in the same session and to run it for as long as we need, potentially up to the full hour and a half. But we can just play this by ear a bit. Two other pieces of admin. Just to let you know that we've got venue reservations already in Oxford for Ketamine 2022. So I hope that you'll be interested in that. What we'd like you to do is to save the date in your diary, which is the 4th to the 6th of April next. And there'll be a hybrid element to that. And finally, we'll be sending out a survey about this conference at the beginning of next week. Please do fill it in and help us to improve what we offer. And if you would like a certificate of attendance, then you will need to fill in the survey to get that. Just say that you want it on that survey, and we'll arrange for that to be sent to you. So in this session, we're looking forward to hearing from Elizabeth Ballard from NIMH in just a moment. But first, we're going to start with a presentation about ketamine for the prevention of postpartum depression. And this is by Dr. Psyying Wang. Psyying and her husband are both anaesthetists, and we're both authors on the paper of this study, and they're from Wuhan, and so we're absolutely in the thick of it a year ago. She's a deputy chief physician of the Department of Anesthesiology at the 3rd Jiangye Hospital of Central South University in China. And she's mainly engaged in clinical anesthesia, postpartum depression, and pharmacology for anesthesia. And she's going to present data from her recently completed clinical trial about the prophylactic use of ketamine to reduce postpartum depression in Chinese women undergoing a cesarean section, which was supported by the National Natural Science Foundation of China. So Kevin, if you can launch that now, that would be great. Thank you.
Dear Chairman, fellow colleagues, distinguished guests, my name is Psyying Wang. I'm an anesthesiologist at the Shangya Hospital of Central South University in China. First of all, let me thank Professor Rupert for his warm invitation. Now I would like to make a brief introduction about one of the most important clinical trials. Prophylactic use of ketamine reduces postpartum depression in Chinese women undergoing cesarean section. As we all know, postpartum depression, we call it PPD simply, is a common psychiatric disorder that occurs in the postpartum period. The pathogenesis of postpartum depression has still to be determined, and there is no effective prophylactic treatment for postpartum depression, so more studies should be explored. Ketamine, a non-competitive antagonist of the NMD receptor, has been used for many decades as an anesthetic during the surgery, such as cesarean section, and numerous studies have demonstrated that ketamine produces the antidepressant effect in patients with depressive disorder. So, given the known safety of ketamine, an NMD antagonist in obstetrics, we conduct a clinical trial to determine whether the administration of ketamine can attenuate postpartum depression. Next, I will tell you how we designed and implemented the clinical trial. Our study was conducted in the Shangya Hospital of Central South University. We recruited a total 702 pregnant women who underwent cesarean section with spinal anesthesia between August 2014 and December 2016, and they were all agreed to postoperative intravenous analgesia. We exclude the women with hypertension, significant electrocardiogram abnormality, lack of capacity to consent, and inadequate understanding of Chinese, drug dependence within 6 months. Finally, a total of 654 patients were included in the study. Participants were randomly assigned to two groups using a random number sequence method, the ketamine group and the control group. At 10 minutes after delivery, ketamine 0.5 mg per kilogram diluted to 10 ml with 0.9% saline was administered in the patient by intravenous injection in the ketamine group, but not in the control group. After operation, for the patient in the ketamine group, subentanea 100 microgram ketamine 160 mg and phenylcitin hydrochloride 0.25 mg in 100 mm saline were given using a patient-controlled intravenous analgesia device. We call it PCIA device. For the patient in the control group, subentanea 100 microgram and phenylcitin hydrochloride 0.25 mg in 100 ml saline were also given using a PCIA device. The parameters of both groups are set to infusion rate 2 ml per hour, bolus dose 2 ml, lockout time 8 minutes. This study had two primary outcome measures, including first, the prevalence of postpartum depression according to the Edinburgh Postnatal Depression Scale. We call it EPDS. Second, the prevalence of postpartum blues at 4 to 6 days postpartum, which is defined as a mild and short-lasting ailment. And if postpartum blues last longer than 2 weeks, then it is classified as a neurotic depression, which may need psychosocial treatment or drug therapy. Edinburgh Postnatal Depression Scale (EPDS) has 10 items, and each item is scored on a 4-point scale, scored 0 to 3. A total of EPDS score of 0 to 30 points were calculated. The last question item of the EPDS assesses suicidal ideation. I have to mention that an EPDS score more than 9 scores is defined for antenatal depressive symptoms and postpartum mood disorders. We also take some secondary outcomes into consideration, including the perioperative condition, such as a change of heart rate, oxygen saturation, and blood pressure during operation, intraoperative adverse effects, and postoperative pain levels evaluated by the 11-point numerical rating scale. After operation, the patient was followed up by another trained investigator belonging to the experimental procedure at the hospital at first and second days postpartum and at 4 to 6 days postpartum and 6 to 8 weeks postpartum by telephone. Only the anesthesiologist, who were responsible for ketamine injection and the PCIA device, knew the group assignment, and the participants and other trained investigators were belonging to the group allocation. Demographic and basic information were collected for all participants, including age, body mass index, employment and partner employment condition, artificial impregnation or natural pregnancy, domestic violence, primipara, planned pregnancy, education, pressure during pregnancy, antenatal depressive symptom. After we collected all the data, we used the statistical method to analyze and process them. Finally, we got some interesting results. First, the demographic and clinical characteristics did not differ significantly between the two groups. Second, the prevalence of postpartum depression and postpartum blues in the ketamine group were significantly lower than that in the control group. We can see clearly from the table the EPDS score at postpartum day 4 was significantly lower in the ketamine group compared with the control group. What's more, the prevalence of postpartum blues was significantly lower in the ketamine group, which accounts for 11.9% than that in the control group, 18.3%. Moreover, the postpartum prevalence in the ketamine group was 12.8%, which was significantly lower than that 19.6% in the control group. Third, antenatal and postpartum suicidal ideation levels were not significantly different between the two groups. However, the reduction of suicidal ideation was significantly higher in the ketamine group compared with the control group. Last, logistic analysis showed that the administration of ketamine was a protective factor against postpartum depression. On the contrary, stress during pregnancy, antenatal depressive symptom, and antenatal suicidal ideation were risk factors for postpartum depression. Above is the primary outcomes. We also found some interesting secondary outcomes. At first, the analysis of covariance with repeated measurements showed that there were no significant difference in the change in heart rate, the blood pressure, and oxygen saturation during operation between the two groups. Then adverse events occurred in the ketamine group during operation, including vomiting in 62 patients, dizziness in 18 patients, hallucination in 4 patients, and nystagmus in 11 patients. In addition, the hallucination symptoms in patients were temporary and recovered immediately. No other psychotic symptoms such as paranoia, amnesia, or thought disorders occurred in the ketamine group during the operation. In comparison, adverse events in the control group including vomiting in 30 cases and dizziness in 14 cases. In general, the occurrence of vomiting were significantly less in the control group compared with the ketamine group. No other adverse reaction were observed in the control group. And during PCI time, The obvious adverse reaction were found in both groups. Last, the mean numerical rating scale score in the first and second operation day did not differ significantly between the two groups. As shown in the table, the mean numerical rating scale score in the first and second post-operative day were 1.85 and 1.20 in the ketamine group, respectively, which was comparable to that in the control group, 1.77 and 1.22. Based on the result led to further discussion. The present study investigates the prophylactic antidepressant effect of ketamine in patients undergoing a cesarean section. Ketamine administration results in a significant improvement in postpartum psychiatric disorders, as evaluated by the APDS. Furthermore, ketamine exerts an antidepressive effect in patients with moderate stress level during pregnancy and in those with antenatal depressive symptoms and antenatal suicidal ideation. The NMD receptor antagonist ketamine has been shown to produce repeat antidepressive effects in both the clinical and clinical studies. In the present study, we found that the subanthelic dose of ketamine 0.5 mg per kilogram significantly reduced depressive symptoms in postpartum depression, whereas with a single dose ketamine 0.25 mg per kilogram has been reported to exert no obvious antidepressive effect in postpartum women. Notably, ketamine not only decreased the prevalence of postpartum depression, but also the prevalence of postpartum blues. Thus, our findings support the idea that the ketamine can prevent postpartum psychiatric disorders. How ketamine works in postpartum depression. Although the antidepressive mechanism of ketamine in women has not been explored clearly, according to some hypotheses, ketamine produces the antidepressant effect by blocking the NMD receptor and subsequently activates the mammalian target of rapamycin, mTOR, and inhibits the eukaryotic elongation factor 2, EEF2, signaling pathway. First activation of mTOR signaling results in an elevation of synaptic spinal numbers and function in the prefrontal cortex, whereas EF2 phosphorylation can destabilize the translation of brain-derived neurotrophic factor that may influence the neuroplasticity. Furthermore, our study supports a previous work showing that antenatal depression is a risk factor for postpartum depression, and approximately 39% of patients experiencing antenatal depression develop postpartum depression. These findings highlight the overlapping pathogenesis of postpartum depression and antenatal depression. Ketamine is well known to produce strong and rapid antidepressive effects in depressive disorders. Thus, we found that ketamine lowered the incidence of postpartum blues in the first week of the postpartum period, and it was associated with a long-term decrease in mood in postpartum women. These results suggest that ketamine may reduce depressive symptoms in the early postpartum period, which contributes to reducing the postpartum depression risk. In summary, we found that the prophylactic administration of ketamine during the preoperative period was beneficial to the postpartum mood. Ketamine administration was relatively safe since it produced only some transient adverse effects, and no obvious adverse effect was observed during the use of PCIA. The future studies are oriented to determine whether the side effects of ketamine can be prevented by other administration routes. In addition, it's necessary to explore the precise antidepressive mechanism of ketamine in women in the future. That's all I want to talk. Thank you for your attention.
Okay, so some very interesting data there, some interesting ideas. The paper has been published, so that's available. But I would just ask you, if you have questions about this, to put them in the chat straight away, because we'll send them off to Tsai-Ying Wang, and she's kind of going to answer them before she goes to bed, which is imminent. So if you could do that straight away, that would be great. I think without further ado, though, what we'll do is move on and go on to our next talk. It's a great pleasure to welcome Elizabeth Ballard. Elizabeth is Director of Psychology and Behaviour Research, and she's Director of Pre-Doctoral Training at the Experimental Therapeutics and Pathophysiology branch in the National Institute of Mental Health. And she's going to discuss the implication of ketamine as a potential anti-suicidal treatment, and will provide an overview of clinical and neural correlates of suicidal thoughts in response to ketamine. So over to you, Elizabeth.
Great. And if somebody could tell me if my slides,
yes, they're there.
Okay.
Yeah.
Great. So thank you so much to Rupert and Sarah for organizing this. Of course, it would have been nicer to be all together, but hopefully another time. So what I'm going to be talking about today is ketamine for suicide risk. And I particularly want to highlight some of the issues that arise when you do sort of clinical trials around suicidal thoughts, especially since it's not a clear psychiatric diagnosis. So first, I have no conflicts to disclose, but I am a federal employee for the US government. And so any opinions expressed are my own and do not represent the opinions of the US government. So what I'm going to do today is first talk about an overview of suicide research and the need for interventions, leading to some selected literature on ketamine and suicidal thoughts. And then lastly, as there's time, I'm going to talk about potential markers of suicide ideation response to ketamine. So I'm going to start here. So suicide rates in the United States first. It is clearly a crisis, a public health crisis. In 2019, more than 47,000 people in the United States died from suicide. The suicide rate has been increasing over the last 15 years. There was a glimmer of hope in 2019 that the suicide rate actually decreased 2.1%, but it was inconsistent across racial groups, which basically means that the suicide rates declined in white people, but other racial and ethnic groups, it stayed the same or increased. And that's particularly concerning because there are some indications of a suicide crisis among Black youth in the United States. However, this is an international conference, and so I do want to highlight sort of suicide rates over the world. This is from the WHO, and you can see sort of a wide variety of suicide rates according to country. I also wanted to highlight some of these breakdowns by sex. So this is suicide rate across regions of the world. And so on the top, you have both sexes, then male and female. So I wanted to emphasize there is this potential sort of sex difference in terms of suicide rates, in terms that men die by suicide more than women. But I think it's important to remember that it's not set in stone. You can see much more dramatic sort of gender differences or sex differences in Europe as compared to places like the Western Pacific. And so there's clearly some environmental, social, and sort of other issues involved sort of with these sex differences in terms of the suicide rate. I won't belabor this too much, but this is a conversation, at least in the American media, is the unknown effects of suicide and the COVID-19 pandemic. As a reminder, these are key suicide risk factors: anxiety, hopelessness, depression, social isolation, financial stress, unemployment, insomnia, and a lot of these things sort of are on the increase in terms of quarantine, in terms of social isolation involved in the pandemic. I think the literature thus far is mixed on the actual suicide rates increasing, but I think we're not sort of out of the woods yet with this pandemic, and it's really going to be interesting to see what happens as countries open back up, as people sort of get back to what is considered normal, and what sort of the suicide rates are going to do. So why don't we know more? That's a big question about this. This is sort of the leading cause of psychiatric related death. Why don't we know more about suicide? So first, there's always the ethical concerns. And what we're finding more and more is that depression trials are actually becoming more restrictive. It's just very difficult to do this ethically and safely, work with suicidal individuals. And so more and more, we're actually finding depression clinical trials are more likely to exclude suicidal individuals because sort of the headaches and the intense follow-up that's needed is sometimes sort of not feasible. There's also the issue of the conflation of long-term and acute suicide risk factors, particularly the difference between what is a risk factor for suicidal thoughts and what's a risk factor for suicidal behavior. And so what we know is that suicide risk factor research really has not advanced over the last 50 years. They've done meta-analyses, and overall, psychology, psychiatry, we're really studying the same risk factors over and over again. There's no objective measures of suicide risk. And in particular, if you're thinking about patients, they might have some really sort of important and valid reasons to minimize their suicidal thoughts and behaviors more than other psychiatric symptoms, including concerns for hospitalization, observation status, or wanting to be discharged. And then lastly, we have few treatments for suicide, and even fewer studies looking at sort of the mechanistic understanding of what's underlying sort of changes in suicide risk. So this is the model that I use when I'm sort of thinking about sort of suicide risk and sort of suicide risk groups. And so on the y-axis, you can see low to high suicide risk. And then the conceptual idea is that there's a certain threshold at which somebody might make a suicide attempt. So we have individuals at low suicide risk. So many people do not have a psychiatric diagnosis, do not sort of consider suicide in their lifetime. There's individuals that have a psychiatric diagnosis, but sort of never get to the point where they seriously consider or attempt suicide. There's the individuals who have attempted some time in their life, they've reached that threshold, but they got treatment, they got better, sort of circumstances changed. And so they're no longer, currently experiencing suicidal thoughts, but are sort of at elevated risk over their lifetime. And then there's somebody sort of in active crisis. So somebody who is at the point that you are concerned, if you are discharged, I'm worried that something might happen and you might try to kill yourself. And so the point I'm trying to make is that treatment really differs depending where you are on this continuum. In terms of intervening at the point when somebody is developing a psychiatric diagnosis, that's going to look very different than when somebody has attempted, sort of has resolved, and then you're working on preventing a future attempt, as compared to sort of how you treat the active crisis when somebody is in your office and expressing suicidal thoughts and intent. And so then the model that I use and like to think about is sort of combining those last two issues in terms of how do you reduce suicide risk in the short term? How do you get somebody out of the crisis? But then how do you connect somebody to a treatment that might reduce sort of risk for suicide attempt over the long term? So again, it's probably going to be a different sort of treatment that gets somebody out of the suicide crisis than sort of the lithium or CBT or DBT that you might link somebody up with in terms of maintenance of the response and particularly prevention of future suicide attempts. So I always want to just highlight that there are, of course, few, but there are some treatments for suicidal thoughts and behaviors. There's the traditional treatments we all know about in terms of pharmacotherapy, including lithium and clozapine, psychotherapy, including cognitive behavioral and dialectical behavioral therapy. There's the longstanding use of electroconvulsive therapy. But obviously the point of this conference today is to talk about the next generation treatments, and particularly those studied by the group that I'm in at NIH, ketamine led by the work of Carlos Zarate, and then TMS, and as well as ECT under the PI of Dr. Holly Lisenby, who's an expert in this area. So that is sort of my overview of suicide research and the need for these types of clinical trials. And now I'm going to talk a bit about ketamine and suicidal ideation. So as a reminder of all of these things that I just talked about 3 minutes ago, there's a number of obstacles to suicide research. So for this presentation, I wanted to highlight 3 different papers to discuss potential issues, concerns, and sort of paths forward in terms of understanding suicide risk. So the first is this meta-analysis of a number of different trials of ketamine that looked into suicidal thoughts. In part, I am mentioning this because both Sam and I were on this paper. But also I think is a good example because it was a meta-analysis that used individual level data so that we were able to combine the entire samples and not just look at overall effect sizes by groups. So basically with the literature up until this point, and so then this is a mix of people who are in a depression trial, who happen to report suicidal thoughts, as well as suicide-specific clinical trials, you do see potentially overall an effect of a single dose of ketamine on suicidal ideation. The effect was independent of antidepressant effects. And you do see a proportion of individuals after this ketamine dose report no suicidal thoughts whatsoever. So another example comes out of the Columbia group is Grunebaum. And so this is a suicide-specific clinical trial. So that's required to have an MDD diagnosis. So it's a depression and suicide clinical trial, pretty severe on a depression rating scale, and then significant SI of 4 or more on the scale for suicide ideation. And so in terms of interpreting these graphs, the most important analysis that you're looking into is the comparison between green and red. So the midazolam is the control. So you can see on the top, so there was 1 infusion of sort of this parallel trial, and then non-remitters in the midazolam group received open label ketamine, and so that's sort of the orange bars. So again, focus on sort of the comparison between the red line and the green line. And so overall, you do see these effects of ketamine on suicidal thoughts, at least up to day 1. It looked like sort of on the bottom, you see the depressive effects. So they found a little bit more inconsistent results. They found it on 1 depression measure, but not on some of the others. So as you can see this, and then everybody ended up getting ketamine eventually. So that's why you see a lot of these lines converge. So overall, a promising trial, sort of got a lot of press, and I think was a well-done trial. Another well-done trial that I think about a lot is this trial out of Ionescu's group. This is out of MGH. So this is a multiple dose ketamine randomized clinical trial related to depression and chronic suicidal ideation. So I want to be sort of very clear about what that sort of entails. So that's a depression score over 3 failed trials of an antidepressant medication, and then suicidal thoughts for over 3 months, as measured sort of by the Columbia Suicide Severity Rating Scale, and then sort of current suicidal thoughts. So this study did not find an effect of ketamine on suicidal thoughts, and there did not appear to be much of an effect of ketamine on depression. And so I think it's really important to bring up first, just, this is science, we need to know sort of the mixed literature, but also really think about sort of what patients we're trying to treat and sort of who might be most appropriate for interventions like ketamine. And so I would mention to you all that compared to the depression clinical trials, we have a long established literature on how we think about depression clinical trials, how we do ratings, how we do treatment resistance. Suicide clinical trials, particularly in the pharmacologic realm, are relatively new. And so there's a lot of standards that we don't know yet, we're still working on. So if somebody were to say to me, do you think that ketamine works for suicidal thoughts? I would say, yes, I think it works for some people, but we just need to figure out which people those are. And I think it's just like depression, it's just like other diagnoses that we really need to figure out sort of who does this work best for. And just thinking about the trials that we have, what really a lot of factors that we need to investigate more are things like screening for inclusion. Is this a study of chronic suicidal thoughts? So are we thinking about somebody who's been chronically ideating for 3 to 6 months? Is this somebody in active crisis in an emergency room and needs to either be psychiatrically hospitalized or sent home? So I think those are key differences that we really need to pay attention to as we think through this literature. As with all of this rapid antidepressant intervention literature, we need sensitive assessments. A lot of these assessments that we're using in these clinical trials were not designed for these rapid changes. Assessment over time. So we just have to pay attention to which measures we're using and which ones are most appropriate. There's a question of appropriate controls, especially if you're working with a suicidal patient. Is it ethical to give them a placebo and potentially withhold treatment? Usually our ethical review boards have some questions about that. There's also just the aspect that the suicide crisis is quite limited and often resolves very quickly. And so thinking about sort of what's the appropriate assessment window and controls. And then lastly, for the clinicians in the group, what is considered a meaningful suicide ideation response? Does 50% remission of suicidal symptoms, is that clinically meaningful, or are you trying to get sort of suicidal thoughts go to zero? And then the bigger issue is that these studies are all related to suicidal thoughts rather than suicidal behavior. And we don't necessarily know that just by reducing suicidal thoughts, does that prevent somebody from making a suicide attempt. Obviously, we need huge samples in order to evaluate that. So I wanted to spend the bulk of my time sort of on those two big issues. And so in the interest of time, I'm going to speed through the next section a little bit, but I'm very happy to talk more at the extended discussion section at the end of the day. So now I'm going to talk about potential markers of SI response, because I really think, as I was saying before, we do think ketamine works for suicidal ideation in some individuals. So let's figure out who those people are and why. So I'm not going to belabor this. I already talked about the limitations of suicidal ideation as an outcome. Patients have reasons to minimize suicidal thoughts. Depression is heterogeneous. How do we distinguish suicidal thoughts from other depressive symptoms? Suicide ideation is a dynamic process, and it can ebb and flow over the course of the day. Patients can be chronically suicidal and never attempt. They can also make an impulsive attempt with little forethought. So one way in terms of the heterogeneity of depression, we've sort of been working at this is through exploratory factor analyses across commonly used depression rating scales. And so we did one of these with the HAM-D, MADRS, SHAPS, and BDI. And so going forward, for the most part, when I'm talking about suicide ideation, it's from one of these. Then what we were able to do with these factor scores was look at responders, SI responders to ketamine. So this is with NIH data. So doing a latent growth curve analysis, we wanted to look at sort of identifying individuals who did not respond to ketamine, who had somewhat of a response, and then basically the remitters, the people that had sort of no response, complete response, was no suicidal thoughts after they received ketamine. And so we're able to identify these three classes. And I want to just mention that this was separate from antidepressant response. Happy to talk through that more, but basically this isn't necessarily sort of the groups you see for antidepressant response to ketamine. In particular, it did seem like for the remitters, there was more of a relationship between ideation and depressive response, but some of the SI non-responders did have an antidepressant effect. So it was more independent in the other two groups. So we did identify these classes of responders, looked at baseline predictors. Basically, we found people with a chronic suicidal thoughts were more likely to be in the non-responder group. People with a history of self-injury were more likely to be in the non-responder group. So I'm thinking about sort of who might be most appropriate for that. That's important to keep in mind. However, we're scientists here, so I do want to say we looked at a lot of factors. So this is sort of all of the different potential markers that we looked at, and then highlighted in red are the ones that were predictive. So I want to sort of be full disclosure, we threw the kitchen sink at this and only found a few factors. And so clearly we need to think about this in new ways to really understand baseline predictors of SI response to ketamine. Then Just going to check the time. So I'll sort of go through these, like I said, fairly briefly, but I'm happy to talk about them more. We've looked at PET imaging and suicide ideation response, specifically glucose metabolism in infralimbic cortex is associated with suicidal thoughts. Depression was not. Metabolism in this area was also associated with ideation decrease after ketamine. We've been doing MEG analyses on gamma power. On the top, you have sort of patterns of activation as related to suicidal ideation. On the bottom, you have depression. So you can see that they are fairly distinct brain areas activated, and worked with Dr. Gilbert in my lab to model connectivity. And again, showing sort of this differentiation between what you find with suicidal thoughts as compared to depression. Another analysis by Dr. Allison Nugent on MEG looked at functional connectivity, looking at a number of factors from this EFA, depressed mood, tension, negative cognition, SI, and A motivation. Actually only found anything related to suicidal thoughts, and the hub area included the left hippocampus, anterior insula, and dorsolateral prefrontal cortex. Sleep is another important risk factor for suicide. We know in terms of United States data that overnight is a particularly high risk time for suicide death. And if you have individuals who are depressed, we know that insomnia is one of the core symptoms of depression, that you do see increased wakefulness over the course of the night. So these two examples are depressed patients and healthy controls. And you do see on the left a lot more wakefulness. So it's over the course of midnight to 5 a.m. You see a lot more wakefulness as compared to individuals without a depression. And so one analysis we did was looking at the sleep quality of depressed ideators. And basically when you put this all into the model, so we have individuals on the left who had suicidal ideation the next day, on the right, individuals who did not. If you put this all into the model, time awake spent at 4 a.m. predicted suicidal thoughts the next day, even when adjusting for depression severity, age, diagnosis, and the like. And what's more relevant is that this relationship between suicidal thoughts and nocturnal wakefulness was shown after the ketamine infusion. So on the left, you have patients with continued suicidal thoughts after ketamine, individuals who had suicidal thoughts, received ketamine, went to sleep that night, woke up and still had suicidal thoughts. So that's the sleep on the left, as you can see, is still fairly disrupted. And then on the right, patients without suicidal thoughts after ketamine, individuals that had suicidal thoughts, went to sleep that night, woke up the next morning, and no longer had suicidal thoughts. And so you can really see this relationship potentially between ketamine and sleep that might be related to the anti-suicidal response of ketamine. So we are doing new analyses that I can discuss more, but basically we're looking a little bit deeper into the brain, looking at alpha and beta activity as related to next day suicidal thoughts. I will say that what we found is sort of oscillations in beta activity, particularly seem to be related to suicidal thoughts. And then lastly, we're looking at new metrics, not just looking at suicidal thoughts, but risk for suicidal behavior. If people are familiar with the work of Matt Nock out at Harvard, he has an implicit association task of the self with death as compared to the self with life that does predict suicidal behavior at 6-month follow-up. And so we have an imaging version of this that we've piloted in healthy volunteers, and then are looking in terms of the ability of this task to categorize suicidal as compared to non-suicidal individuals, and have plans to look at this pre and post ketamine. So in conclusion, I hope I have convinced you that there's a tremendous need for rapid acted interventions for suicidal patients now more than ever. I do believe ketamine is a promising rapid acting anti-suicidal treatment, but we really need to understand which patients will benefit the most. And I would argue this mechanistic understanding will at least begin to help us understand in the clinic, sort of where this can be best used. I do not think that it's going to be a direct replication of ketamine's antidepressant effects, but clearly we still need to keep an open mind as we're thinking through this. And then because of the audience that's here, I just want to put in a plug for data sharing and registries, especially for these sorts of behaviors that have a low base rate. I think it's particularly important that we think about how we can share our data and really be able to understand sort of the long-term impact of ketamine and related compounds. So I want to say thank you and sort of to everybody that sort of worked in this group and for this opportunity to present.
Great, thank you very much indeed, Elizabeth. That's a real tour de force, a canter through all things suicide. And thank you very much indeed for that. We're looking forward to going into some of that in a bit more detail, perhaps later with you. So for our audience, we'll meet back here at 3 o'clock in 10 minutes, that is to say. Do please keep the questions coming in the chat. It'll help us to moderate the discussion later this afternoon. So for the moment, thank you very much, Elizabeth, until later. And we'll see everybody back here in 10 minutes. Okay, thank you.
Welcome back, everybody, to the Ketamine 2021 virtual conference. Before presenting the next two speakers, Prof. Adam Winstock and Prof. Samuel Wilkinson, I'd like to remind you to write your question in the chat below. We will then review and answer those during our discussion after today's talk, starting at 5 p.m. GMT. Also, if you have any technical issue, please send a message to Oak AV Zoom support in the chat below. Now, it's my pleasure to introduce you to Prof. Adam Winstock. Prof. Winstock is the CEO of Global Drug Survey. And to give you an idea, the 2020 Global Drug Survey surveyed a large sample of more than 100,000 people. And over 6,500 people completed a specialist section about self-treatment of psychiatric condition and emotional distress with psychedelics. Prof. Winstock is also honorary clinical professor at the Institute of Epidemiology and Healthcare at the University College of London. He's going to present data comparing self-treatment with ketamine and other psychedelics, including safety, effects, supervision, and attitudes to legal use. Following his talk, Dr. Wilkinson, Assistant Professor of Psychiatry and Assistant Director at the Yale Depression Research Program, will present current evidence for CBT in sustaining the antidepressant effects of ketamine. Prof. Winstock, over to you.
Thank you so much, and thanks to everyone else who's joining this fascinating conference. In particular, thanks to Rupert for letting me come along and share this information. So I guess my background is going to be different to many of yours, in as much as I spend a lot of my time working with people who have developed problems with drugs. And if you'd spoken to me 10 years ago about ketamine, I would have harped on about various risks and harms. And I'm having to reorientate myself, like so many people, to, of course, accepting that so many things that people use for pleasure, of course, can be used for positive therapeutic benefits. And I want to take you through some of the data that we've collected over the last 5 or 6 years that I hope you will find interesting. So I want to look a little bit around kind of global patterns of ketamine use, focusing on recreational use. And I want to do that because I think it's important for us to kind of understand whether regulators are going to be looking at this information, being fearful of what ketamine may do to people who are using it. I then want to move on to some of the work we looked at, focusing on the acceptability of psychedelics in psychiatry. And then I want to finish looking at some of the work I've done with Rupert and his team on people's experience of self-treating with psychedelics, including ketamine. So Global Drug Survey is an independent research organization. We're basically a network of academics in about 13 different countries. And since 2013, we've collected data from over 900,000 people. The survey is normally translated into at least 10 different languages. It's an online encrypted survey. We don't collect IP addresses. And we get lots of people to take part because we collaborate with big media organizations around the world, like The Guardian, Vice, HuffPost, as well as partners in France and Germany and across Europe. this is a non-probability sample. This is not prevalence data, but it adds to the smorgasbord of data. And the truth is, no single data set or no single methodology is going to capture everything we need to know. It's about triangulating data. And Global Drug Survey is particularly useful for exploring in depth patterns of use of particular drugs, as well as spotting new drug trends. We make sure that our data is often available through our media organizations as a way of promoting public health discussion around drugs. But what we also do is repackage our data into a range of free apps and online tools. So that's our way of saying thank you to the community of people who use drugs, who give up so much of their time every year. And we also publish academic papers on a wide range of topics. I think over the years, we've probably collected data in excess of 250,000 people who use psychedelics. We started focusing on this area in 2016. And since that time, we've collected data on more than 50,000 people who have used ketamine, initially looking at things like ketamine bladder and the risk of dependence, as opposed to therapeutic potential. I guess the first thing to say is that ketamine, like so many psychedelics, has seen an increase in use. So as I said, this is not a prevalent study, but if you look across the last kind of 6 years, there has been a fairly consistent increase in the use of most psychedelics, particularly ketamine, where we can see an almost trebling in use since about 2015. But we can also see increases in use in LSD, magic mushrooms, 2CB, and even less commonly used psychedelics like DMT. Because lots of the people tuning in might be from the UK, I thought I'd just quickly put the UK data that says there's been a massive increase in the last kind of couple of years. There was a bit of a drought in 2015, and globally we saw a little bit of a dip, but the UK has embraced the return of access to ketamine with vengeance. So you might look at this and go, well, that's a bunch of non-representative drug users. Do we see this trend in nationally household representative samples? And actually, the truth is we do. So this is the crime survey in England and Wales. This is a national household survey. And you can see there's been a gradual increase over the last 15 years in people reporting the use of ketamine, particularly in those people aged between 16 and 24. And very similarly to the GDS data, an almost doubling in use over the last 3 years. And I think one of the things that makes ketamine attractive is that it's cheap. And in terms of bang for buck, it's one of the best value for money drugs out there. I guess one of the important things to recognize is that although in the media, what we focus on in terms of drug use is people turning up in A&E and people turning up seeking treatment, the majority of people who use most drugs do so infrequently. And that's certainly the case for ketamine. So this is data from about 10,000 people who had used ketamine in the last year. And you can see about 70% reported use on 10 or less occasions in the last year. And in terms of the amount used, most people are using 0.2, 0.3 grams a day. That they're not figures that, if I look at that, hugely worry me. And it's important because frequency of use is such an incredible predictor of harm. A more robust measure, however, might be looking at the proportion of community users who endorse sufficient criteria on the severity of dependence scale and would be classified as being dependent. And you can see here that when we compare ketamine with a range of other commonly used drugs on the street, such as the synthetic cannabinoids, amphetamines, cannabis, MDMA, cocaine, the rates of ketamine dependence are really low. And I think that should be reassuring. But as the little pop-up graph on the right-hand side shows, if we look at kind of the rates of dependence among more frequent users, that goes up really quite significantly to above 40%. And here we can see that's the case for all drugs. The best thing we can do for society is basically say to people, if you want to use drugs, don't use them too often, don't use them too frequently. If you don't use drugs that frequently, you don't build up tolerance, your risk of developing dependence is really low. But when we start looking at people using weekly or more, the rates of dependence, even for a drug like ketamine, actually start approaching levels that I think are potentially a cause for concern. Another way you can track whether or not drug use is a concern to people is just say to people, would you like to use less of that drug in the next 12 months? And about 20% of people who use ketamine in the last year say yes. That's obviously far less than for stimulant-based drugs. One of the real metrics we're interested in is the risk of acute harm. And so every year for the last 8 years, we've asked people, Have you had to seek emergency medical treatment following the use of different drugs in the last year? And consistently, the safest drug is always magic mushrooms. It's not a drug that's taken very frequently, but you can see even for ketamine, it's about 0.6% of last year users reported seeking emergency medical treatment. And for most of the times, that's self-limiting, it's acute, it's panic attacks, it's cardiovascular stress, it's K cramps. But again, not data that would immediately concern me. We previously looked at work focusing on the risk of ketamine bladder. And this was from a sample of lots of thousands that did suggest that ketamine bladder was a real risk among heavy recreational users, and with 1 in 4 reporting at least one symptom, such as dysuria, frequency, hematuria. This work highlighted that most people didn't seek help. Most people, when they did seek help, didn't declare their ketamine use, but the majority of people who stopped using actually seemed to get better. But the biggest risk was frequent use, particularly with alcohol. So as interest has grown in the use of psychedelics, we were interested a couple of years ago to look at just how acceptable psychedelics would be to people as treatment. We had a fairly large section on this, but over 20,000 people filled in a section where we drilled in depth the acceptability of different psychedelics. These 20,000 people had already suggested that they would be open to the idea of taking psychedelics for the treatment of psychiatric conditions. And the way we asked this was we created a hypothetical scenario. Basically, it was about going to a GP with depression or PTSD, but with symptoms that were significantly impairing on your daily functioning. And the GP basically says to the patient, well, there's a range of different treatment options. What would you be interested in? In terms of the people who answered this section, what's important to recognize is 80% of them had had experience of psychedelics, 43% had ever reported being diagnosed with a mental illness, and about 20% were currently in receipt of some sort of psychiatric medication. That's going to become important when we look at the acceptability among different groups. So this was the hypothetical scenario, basically saying, I think you need some sort of medication or treatment, but I'm going to give you a range of options. And they were given this range of options. I don't know how many people in the survey actually read through all of this, but I can tell you we spent ages getting this right. But it's basically describing what the treatment was, where it would be conducted, how long it would take. And people were then asked to make informed decisions about how likely it would be they would accept these different treatments. So there were traditional psychiatric treatments such as antidepressants, there were talking therapies, and we also included mindfulness almost as a control. So across the whole sample, and this is probably about actually 70,000 people, because we asked this as an introductory question, you can see that low dose LSD, talking therapy, high dose LSD, hugely acceptable. In fact, much more acceptable than traditional psychiatric medications. And that's a little bit of a wake-up call to those of us who are psychiatrists. Ketamine, slightly less acceptable than some of the other psychedelics, and I'll come to that in more depth. One of the really important things I learned from this is that people's past experience played a huge role on how acceptable traditional psychiatric medications were versus psychedelics. So you can see acceptability of antidepressant medications were much lower among people who had used psychedelics. So you can see that people had had a psychedelic history. It was only about 35% said it was very likely or likely that they would accept antidepressants versus well over 50, almost 60% of people with no psychedelic history. Likewise, people who had previously used psychedelics recreationally, almost 80% of them said they would be open to using psychedelics for treatment. But what's interesting is almost 50% of people who had never used psychedelics also said they would be open to using them. And that's actually higher than for traditional psychiatric medications. If you put it all together, basically it came out that LSD and MDMA were the most acceptable medication-based treatments. And because across the board, the most acceptable treatment was talking therapy, it also reminds me just how important psychedelics have been at merging talking therapies and pharmacology. And I think for years, practice really hasn't given us the time or structure to actually do that. But you will notice that actually ketamine, either high dose or low dose, was slightly less acceptable. And I think there is something around a reputational problem that ketamine may have. Maybe that's because of fear of dependence or ketamine bladder, or maybe it just isn't as light and fluffy as psychedelics and hasn't had the same sort of positive press. And I think that's maybe something for those people in the field that we want to start challenging. The other thing that for me that was quite reassuring is that for those people who identified any sort of psychedelic as a primary treatment preference, the reason they wanted to use a psychedelic or dissociative drug was because they wanted to get to the root of their problem and they wanted to work with a trained therapist. It wasn't that they wanted something that was quick and easy, that didn't require reflection and working with a trained professional. And I think that's really reassuring. Last year, however, what we were really interested in is that given the fact that there's been lots of press about these medications, but we know that most people can't access them, we wanted to know whether people had started to try and self-treat their mental health with these drugs, either under supervision or just on their own. And that's the data that I want to present now. So this report came out a couple of months ago, and the psychedelic data was based on a subsample of about 25,000 people who had used LSD and magic mushrooms. The self-treatment section was focused on around 6,000 people. The first thing to say is lots of people who use LSD and psilocybin already seem to be using them for functions other than pure recreational fun. 50% said they were using LSD for enhancing well-being, 13% using it to address a psychiatric condition, 30% to address a specific emotional worry or concern. And that was a very similar figure for people using magic mushrooms. For both groups, about 25% said they had experimented with microdosing in the last year as well. In terms of what psychedelics were people most likely to use to self-treat, top of the list was LSD, followed by MDMA, then magic mushrooms, and quite a lot further down the line was ketamine. So it's not as popular, but certainly we had people who reported using it to self-treat. What were they trying to self-treat? They were trying to self-treat the conditions that are common in society. So most commonly depression, anxiety, relationship problems, trauma, PTSD, and a range of other things that we know there is currently work on exploring the utility of psychedelics. What I want to take a little bit more time to focus on now is to present the work that's largely been done by Rupert and his excellent MSc student, Sophie Gray, who took our data and is producing the first of a series of papers on people's experience of self-treating psychiatric disorders with different psychedelics. So the data that I'm going to present here on ketamine is basically comparing the patterns of use and experiences of just under 7,000 people who were pure recreational ketamine users and about 700 people who identified self-treating with ketamine as the major drug that they had used to try and self-treat. For both groups, we had a majority of male recipients and about 20% were under the age of 21. But you can see there were really high rates of existing diagnoses. We had about 50% with depression, a slightly smaller percent with anxiety, and about 20% with ADHD. And the current global drug survey, which has just finished, we've specifically looked at ADHD and people's response to stimulants. There is this other group at the bottom that I'll talk about as well, who were just a group of people who reported never using ketamine for any other reason other than to treat their emotional distress or psychiatric disorder. Because importantly, 80% of the people who said they were using ketamine to self-treat also said they were using ketamine on occasion for recreational purposes. So the first thing to say is people who were using ketamine to self-treat mental illness very often had tried other psychedelics in the last 12 months to address their concern. 40% had used LSD, 36% MDMA, a quarter magic mushrooms, 13% had used DMT. And the vast majority had used psychedelics more widely to improve their emotional health and well-being. As we frequently see, people who tend to use more drugs more frequently tend to use the target drug more frequently. So people who reported having used a large number of different psychedelics to try and self-treat their condition tended to use much more frequently than people who were just using a single psychedelic. As you can see, poly self-treaters were using on 127 days. That is a lot. How did self-treaters, though, compare to recreational use? Well, self-treaters tended to use more frequently and to use more ketamine. Recreational users, 12 times a year, using 0.4 grams on an average occasion. Only about the majority of people not using with alcohol, and that's important. But for people who were self-treating, they were using on average 37 times a year, so once every 10 days, and were using a slightly bigger dose of about 0.5 gram a session. The exclusive medication group, people who only use ketamine for medical reasons, used on average 30 times in the last year and were using about 0.6 of a gram. Interestingly, of this group, 18% reported using intravenously and 10% orally. But these weren't people who were just putting all their eggs in the ketamine basket. They were seeking other therapies as well. In the last 12 months, this group had accessed talking therapies, a third had seen a therapist and were also taking some sort of psychiatric medication, 44% reported taking mindfulness. And interestingly, 72% said they had taken ketamine within 24 hours of their prescribed medication with no significant adverse effects. And that's really important because I think it's what differentiates ketamine particularly from the psychedelics, where the chronic use of SSRIs may actually blunt the therapeutic response. And so then you've got the challenge of maybe having to withdraw long-term antidepressant treatment before embarking on a novel therapy. We don't have to do that with ketamine. We weren't just interested in the dose, but we were interested in the intensity of the experience that people were normally having when they took their ketamine dose. So a third reported having an intense psychedelic experience, dissociative, hallucinatory. A third, a moderate experience, 20% mild, 5% mild or minimal. I'm not quite sure what doses they were taking. But in terms of adverse effects, a third said they had experienced negative consequences in the last 12 months. And not surprisingly, it was people who were taking more ketamine more frequently who were more likely to report negative effects. 42% reported concerns about come down, tolerance and dependence, and 42% acutely reported mental confusion, memory problems, and racing thoughts. 38% reported feeling disconnected, but I guess you'd kind of expect that. But overall, and remember, this is an unsupervised environment without any guidance, about 50% reported no negatives at all, or they are only very mild. I guess the question that you want to know the answer to is, does self-treatment work? I think broadly speaking, the answer is yes. 56% reported moderate to strong positive change in the overall symptoms of the psychiatric condition they were trying to treat. 65% reported improvement in their depression. We've got, 44% becoming more tolerant to other people, almost 60% reporting increase in understanding of why they feel the way they do. Those kind of more subtle things that we don't often measure in psychiatric treatment trials, I think are really important. But people reporting reductions in social anxiety, people perhaps reporting positive changes in what's important in life. I think in an uncontrolled environment, although this is all self-report, these things for me were far better than I had expected. People reported the onset of positive effects as quickly as we see in clinical environments, 47% reporting positive effects within 12 hours. For 45%, positive effects lasted for more than a week. 20% positive effects lasting for more than 2 to 4 weeks. In fact, some even reported detectable positive effects after 6 months. And of the 30% reporting negative effects, 43% noticed it within a week, but 80% said those actual effects had disappeared within a week. I think all of this is a really positive effect profile. But people who were self-treating were more likely to say they wanted to use less. And interestingly, more self-treaters sought emergency medical treatment than recreational users. So almost 3 times as many. It's still a relatively low rate at 1.7%. But again, that's perhaps something that we could reduce to a much more acceptable level with better training, education, advice, and monitoring. I just want to finish off talking a little bit about some work we did on a smaller number of people who reported taking psychedelics under supervision. These were people who were trying to address a specific worry or emotional concern. Again, the things they were trying to treat, the things that are common in society. In terms of what drugs were people taking under the supervision of another person, the most commonly used drug was ayahuasca within a ceremonial setting, but also LSD, magic mushrooms. But you can see ketamine was being used under the supervision of another individual in about 6% of cases. And I think when we talk about facilitation and supervision, as far as people not accessing clinical trials are concerned, being supervised by, oh my Lord, I am so sorry. I don't know how to get rid of that. That is dreadful. Oh Lord. There we are. That's one thing I hadn't banked on. Oh, I'm back. Apologies about that. For lots of people, their facilitator was their partner or their friend. Now, although that person may know you very well, it's unlikely that they're trained in mental health and to manage things if they went wrong. For me, the really interesting bit is how much care and attention were people giving to screening and non-drug preparatory sessions when they were going off to get drugs under supervision of another person. Actually, it was much higher than I thought. When we looked at this 5 years ago, virtually no one was having screening for mental health, but very few people were having non-drug preparatory sessions. I think as we move forward, we need to make sure that people who are facilitating sessions outside medical settings are doing their homework and making sure we don't have vulnerable people at risk at a time of crisis receiving a drug that actually might make things worse. Saying that, when we asked people overall what the experience was of taking a psychedelic under supervision, it was overwhelmingly positive. 52% saying things were very helpful, they got much better. 34% quite helpful, things got quite a bit better. And amazingly, almost 90% said that if that substance was available within a regulated system, they would take it. So for me, all of that is really positive for the direction that psychiatry is moving on. What do I think it all means? I think that we know that how effective medications are when they're appropriately prescribed is hugely dependent on not just the quality of treatment, but how compliant people are. And for people to be compliant, they have to understand that when they're on Zoom and their phone is connected to their presentation, they need to switch their phone off. Sorry. Acceptability is really important, and acceptability is likely to play a key role. I'm going to switch my phone off because my guess is that person's going to phone back. I'm so sorry, guys. So ketamine is really acceptable to many people, but as I said earlier, I think it has a reputational problem compared to LSD and psilocybin. We want to think about that. Drugs that have a positive benefit after a short space of time are really attractive. But I think the worry for ketamine is that we're looking at frequent redosing, and that compared to other psychedelics, ketamine is going to maybe be a drug that people are taking every week or every 2 weeks. And we know that the risk of dependence and harm is related to frequency of use. We need to look at balancing the benefits and risks. And I think to answer that, we need to understand whether large doses given at a lower frequency is better, more effective, safer than lower doses given more frequently. That might be a way of avoiding the risk of tolerance. And we know that if this was given within a private setting, it may be the more socially, economically disadvantaged groups who may be less likely to be able to afford to continue to take S-ketamine, and maybe more likely then to move to using oral street ketamine more cheaply. I think dependence is a risk. I think it's small. But I think we need to revise how we assess dependence on ketamine in the same way that we do with opioids and cannabis. But basically, the longer we delay access, the more people we're going to have experimenting on their own. Like Rupert and many other people, I think we need to register all new patients. We need to have an open access database. We need to standardize measures when assessing self-treatment. We want to consider maybe having guides for unsupervised use. We need better regulation and training for therapists. And we probably want some early warning detection for those people who are at risk of dependence or bladder problems. The one thing that I've been asked lots of times by people who take psychedelics and advocates is, why do we always have to come along to clinics? You know, why wouldn't we just be able to look after ourselves and pick up our medication? And I guess my question for you is, could we ever let people treat their own mental health and well-being on their own with little or no input from psychiatrists? I don't know what the answer is, but it's something that I'm continually being asked, saying, how valid are psychiatrists using these medications when, you know, you've dismissed them for so many years? I don't know what the answer is. My apologies sincerely, guys, for my phone going off. I'm going to leave it there. I'm going to stop sharing my screen.
Well, thank you. Thank you so very much for such an interesting talk and broad data presentation and some provocative question right at the end. I'm sure will trigger also a lot of questions from our audience. So I really encourage everybody to write them down in the chat. And then we will discuss this later. But now, and also in the interest of time, let me introduce our next speaker. We're delighted to have Professor Samuel Wilkinson here with us today. He's going to present his most recent data from the clinical trials he led on the effect of ketamine in combination with CBT for depression. Professor Wilkinson?
All right. Let's see if this works. Can you see the slides?
We can.
Okay. Okay. The audio is all right?
I say yes. Go ahead.
Okay, great. Well, first of all, thanks to Rupert and Sarah and all the many other people who helped in putting this together, and it's great to be here. You know, good morning or good afternoon wherever you are in the world. So I'll first start, and I do have disclosures. I get funding from a nonprofit as well as some pharmaceutical companies for my research, and I'll just mention that. Yale has an institutional conflict of interest with esketamine. I do not. I don't get any royalties or anything like that for esketamine. But I'm delighted to talk about our experience in a line of research that we've been trying to develop at Yale for a number of years now. And it's embedded within our clinical treatment program at Yale Psychiatric Hospital. We started providing intravenous ketamine outside of research protocols as a clinical treatment. Now it's coming up on 7 years ago. And when the US FDA approved esketamine in 2019, we adopted that into our program. And since then, it's probably more like 400 or 500 patients that we've treated with either ketamine or esketamine, and have had a number of a cohort of them who have been receiving treatment for a number of years now. So I want to start with a model that has guided a little bit of our thinking in this, and I think it dovetails nice with Adam's presentation about, you know, how do we treat people long term and minimize the exposure to this drug. So this is the model, and this is from a paper from a few years ago. And just as a caveat, my colleague reminds me, Chris Pittenger at Yale, that all models are wrong and some are useful. Certainly there are many nuances to treatment and such that a model doesn't necessarily pick up on. But here in the left frame, you might call what you a monomodal treatment approach, where more and more I think we're understanding mood disorders as well as a number of other psychiatric disorders as problems with the adaptability or the plasticity of the brain, and that many treatments, it's not specific to ketamine, but many treatments when applied during a depressive episode will enhance the plasticity of the brain and be associated with a reduction in symptoms and so forth. But inevitably, it seems like in many patients, when these treatments are withdrawn, at least for the most severe patients, there's kind of a return to the disease state and a return of symptoms and so forth. So, what we're trying to think about is moving to panel B, where, at some point when the treatment, whatever it is has placed the brain in this period of enhanced kind of plasticity and adaptability, that we can kind of lock down any changes in a positive way, and that can hopefully lead to improved long-term outcomes. I guess one way you can think of this, if you know, depending if you don't have a deep background in neuroscience, and I've tried to explain it to my kids or my wife this way, is that, you know, if you take cement, you know, when it's wet, you can mold it, shape it, you can write in it, and when it hardens, it will continue to take that form. So this is kind of, you know, the high level principles that we've tried to use to guide our thinking. And we are starting our third study that uses this kind of approach to try and improve long-term outcomes. I'll go through each one quickly. The first one, this was several years ago, and this is when, you know, ketamine was still fairly new. We had a protocol where we would give patients ketamine 4 times over 2 weeks, and we would intersperse with that cognitive behavioral therapy. So they would come in one day, get ketamine, and come in the next day, get CBT, come in the third day and get ketamine and CBT the day after that, and so forth. And this would be repeated over 2 weeks. So, you know, our thinking is that we want to kind of intersperse the psychotherapy and the ketamine to try and take advantage of you know, a window of enhanced plasticity the ketamine kind of induces, and that CBT tries to lock that down and lead to improved longer term outcomes. The ketamine would stop after 2 weeks, and the CBT would continue. This is just what we call an open label, you know, single group study. There's no randomization. Everyone who comes in gets the same protocol. We're just trying to learn a little bit, and we ran about 16 patients through this, and we, in this graph, I'm classifying them as either responders or non-responders based on the first kind of 24-hour period after the first ketamine dose. And what you can see here, there are 2 different kind of measures of depression severity in the top panel and the bottom panel. You know, the blue graph, the blue line are those who respond, and you can see that they more or less stay well for about 2 months following the ketamine treatment period. So the ketamine is in the shaded region on the left, and then that stops in about 2 months after that. Where for the most part, the people who responded initially, they kind of, you know, what we think is soaked up the CBT and did fairly well. Those who didn't respond, they didn't really respond to CBT either over a 2 month period. We looked a little further out, and so this was very encouraging. And we looked a little further out and followed these people for a few more months, at least the responders. It was disappointing that eventually the 8 week mark here is where the last graph stopped. They would start to taper off and relapse. But when we compare this to kind of similar protocols, similar ketamine protocols that did not add some sort of CBT after, that's the green and the orange lines. That was from Mount Sinai in Minnesota, some folks there. It did look at least promising for the first, you know, 8 weeks while the patients were getting CBT. This was a very sick group of patients. You know, they're coming for clinical treatment. About half of them had ECT in the past. You know, I think 2/3 or 3/4 of them had a psychiatric hospitalization in their lives. So these were sick patients, and our thoughts, well, maybe the CBT is not long enough. You know, maybe we need to give some, as we call them, booster sessions. So I want to share with you what we maybe call version 2.0 that we finished not too long ago, and these results are under revision right now. But this is this involves a randomization aspect, and so what we did here is, instead of having the ketamine and the CBT overlap, we put them in sequence, and we really only randomized responders. So at this point, we're a little more comfortable giving 6 doses of ketamine. More data has come out, and so patients get ketamine 6 times over 3 weeks, twice a week, and if they respond, they are then randomized to the next phase of the study, either to CBT or treatment as usual. So, you know, this is the next generation study that we finished up a year or so ago. I'll share just a little bit about some of the, again, these are very small pilot studies at this point, so it's not definitive, but we ran almost 30 patients through this protocol. Half were, well, 30 patients that we got responders to. We got to respond to that course of ketamine. There was something like 50 that we initially put through here. And you look at these patients, and they're fairly sick. The median duration of the current episode is about 3 years. The most of them have been hospitalized at some point in their life. About a quarter of them, not quite a quarter, have had ECT, and half of them, qualify for what we call melancholic depression, and a number of they've on average tried about four adequate trials of antidepressant before they tried ketamine. So this is what it looked like, and so we followed these patients for a number of weeks, and the CBT protocol was more extensive, longer, and so forth. And what you can see here is the ketamine, the shaded region on the left is that 3-week course of ketamine, and that stops, and patients continue either getting CBT or treatment as usual. And the patients getting CBT, they start to diverge from those getting treatment as usual. This is a measure called the QIDS. It's a self-report measure. Again, this is a proof of concept study. It's not definitive, but this looked positive to us, and certainly enough to kind of merit further investigation of this type of treatment approach. It was we didn't quite see the same strength of signal with the clinician rated outcomes. This is called the MADRS. This was not significant, but see maybe a little bit of a hint of divergence towards the last month of treatment. We also wanted to kind of gauge, we're thinking that maybe these treatments can interact in a way that produces some sort of synergy. So we're trying to kind of measure what you might call cognitive flexibility. And we've been struggling with the best way to do this over the last several years. But what we used in this study, a subset of patients underwent testing with two kind of psychological measures that measure, you could say, measure flexibility. One is this NBAC task, where you were shown a series of cards one at a time for I think the card stays on your screen for maybe half a second, and you're asked to answer the question of whether this card is the same as the one you just saw or 2 cards ago. And that may not seem like a difficult task, but especially when you get to 2 back, you have to update in your memory, what is that card that I saw 2 cards ago? Is this the same one? And it keeps changing. It's a challenging task. And then the one on the right is this Stroop, where you see, words that spell out colors, but their font is in a different color, and you're asked to read, what the color actually is, the color of the font, or whether what the word actually says, and the timing of it is that's your performance outcome. So again, the hypothesis that ketamine enhances kind of cognitive control or flexibility, and then CBT locks it down. So again, we're still trying to get the best way to measure this. In a subsample of patients that did this, those who responded had a significantly different, kind of change in their accuracy on one of these tasks. This is the NBAC, and they improved at a greater rate than those who did not respond. So, those who, for whatever reason, their symptoms improve, they seem to have better cognitive flexibility or control after this. The Stroop, it was not, statistically significant. Again, these are small samples, and there's a lot of variability. It was kind of trending in the right direction. These show the difference in reaction time before and after ketamine, and stratified by those who respond and those who don't. So what you want to see is a drop, a negative number that indicates improvement. So that's the high level results of our most recent study that finished a year or so ago. We were fortunate to get funding to do a slightly larger study. We're calling it the Endure study, and it's different in a couple important ways. One is that we're only recruiting, at least for the time, we're only recruiting inpatients. these are patients with depression and suicidal ideation who are in need of hospitalization. So, highlighting the importance that Elizabeth talked about earlier this morning about doing research in real patients who have, some risk of suicide. We're trying to recruit those who are at fairly high risk. All patients we are going to receive treatment with esketamine. Given this is funded by the NIH, the thinking was that esketamine would be more implementable. I think it hasn't quite worked out the way some people would have thought, but that's what we're going with for now. So everyone receives esketamine, and then patients are randomized to either CBT or treatment as usual. It's a single blind study. The raters are going to be blinded. Can't really rate blind patients to this. And the CBT is a combination of in-person and computer-based therapy. It's a program called Good Days Ahead, which has been used before in several funded studies in the past, and it's targeted to help address suicidal ideation. So this is a two-site study. It's slightly larger, about 60 to 70 patients, what we hope to recruit. Involves Yale and also Rick Shelton, Matt Macaluso from Alabama, Birmingham in the US. So this is a little bit about what the protocol looks like. Again, patients are in the hospital when they're recruited. They are randomized to esketamine plus CBT or kind of esketamine minus CBT. One of the other things here that's a little different, we're, I guess, compromising between our first two pilot studies, and we're overlapping the CBT and the esketamine somewhat, not completely, but there's a 2-week overlap phase between phase 1 and phase 2. And, we obviously hope to see rapid antidepressant effects and potentially anti-suicidal effects, but I think one of the key things we're looking for here is the long-term game. And so these patients are in the protocol for up to 6 months. So that's protocol. It got off the ground actually just this month. We recruited our first 3 patients this month. Excited to get that going, and it'll be a few years before we get some results about that. But as so many things in research go, this is obviously not just my effort, but I just want to thank so many people at Yale and also our collaborators at University of Alabama, Rick Shelton, Matt Macaluso, who will be coming on board in the next little bit. So these are all the people who've made this work possible, and I would be a little remiss if I didn't thank those who made it necessary. At least for me, that's my children. And with that, I'll answer any questions if there's a little time, or may do that at the end. But thanks for your interest.
Yeah, so thank you very much, Sam, for this talk, for discussing not only the previous data you collected, but also giving some suggestion of what we can expect next from this line of research. However, I think we should stop here, take our break, reconvene back at 4 p.m. Our next speakers would be Jennifer Dwyer, who will talk to us about the use of ketamine in young people with treatment-resistant depression, and Rupert McShane, who will give a perspective on regulation and the use of ketamine. See you back in a bit more than 10 minutes.
Okay, welcome back, everybody. It's a great pleasure to introduce our next speaker, who is Jennifer Dwyer. Jennifer's assistant professor and co-director and co-founder of the Pediatric Depression Clinic in the Child Study Center at Yale University. And she's going to talk to us about what I think is absolutely fascinating and really, really important topic, and that's ketamine for treatment-resistant depression in adolescents. So without further ado, over to you, Jenny. Do please, okay. Sorry, I should just say, do please enter your chat while Jenny's talking, so that we can get the questions ready for the Q&A afterwards. Thank you.
Wonderful. Well, thank you for inviting me. I hear a little bit of a echo. Do you guys hear an echo or no? Oh, I don't hear it anymore. Okay, perfect. Well, thanks for inviting me. I'm excited to talk to you guys about some work that we're really passionate about. So ketamine use for treatment-resistant depression in adolescents. Just some housekeeping stuff. I don't have any relevant financial conflicts of interest to disclose. I've got research support from the following sources. So let's get underway. So adolescence is a critical developmental period. For those of you remembering back, it is the period of transition between childhood and adulthood. So it's sort of conservatively defined as 12 to 18 years in humans. And there's a unique set of behaviors that's conserved across mammalian species. So things like increased risk-taking, novelty seeking, and spending time with your peers. But adolescence can also be a really vulnerable time. It's a time of onset for things like substance use disorders or the emergence of some neuropsychiatric disorders. And so I think both the the strengths and the vulnerabilities are both rooted in the idea that there is significant structural and functional change happening in the brain during this time. So I'm very interested in adolescent depression. Adolescent depression is a significant health problem. So it's been estimated that nearly 1 in 5 adolescents will experience major depressive disorder by the end of the adolescent period. In the US, suicide is now the second leading cause of death in this age group. The TADS trial showed us that 40% of adolescents with MDD will remain depressed despite getting initial treatment with an SSRI, so Prozac in that case. And then the Tordia trial after that showed us that of that SSRI resistant population, nearly half will remain depressed, even if you change their medications and you add psychotherapy. And so that tells us, both the studies and those of us that work with this population, that we really need better treatment options and a bigger evidence base in this population. I share some suicide facts from the CDC. These are pre-pandemic numbers, but surveying high schoolers in the US, so between 9th and 12th grade, 17 had reported considering suicide in the last year. 14% had reported coming up with a plan. 8% reported having attempted suicide in some way, shape, or form, and 3% reporting that they had an attempt that required medical attention. The death rate is 13 per 100,000, which comes out to 5,500 per year. It helps me when I'm thinking about these numbers to have something to anchor it to. So this is a picture of Hamden High School. It's a pretty large high school that's just down the street from us in Yale. There are about 1,100 students. And so this death rate is the equivalent of losing about 5 Hamden high schools to suicide per year, which I think is totally unacceptable and is really a call to action for all of us to try to do something about this. So obviously we're at a ketamine conference, so we're going to talk about ketamine. So I'm going to go quickly through these slides because I know it's a sophisticated audience and you all have been talking about this quite a bit. So ketamine is a medication traditionally categorized as a dissociative anesthetic, a non-competitive NMDA receptor antagonist. It's used at higher doses in anesthesia, so up to like 4.5 milligrams per kilogram, pushed over a minute, versus the doses we've been talking about in psychiatry. So the best study being this 0.5 milligrams per kilogram infused slowly over 40 minutes. So ketamine rapidly improves depressive symptoms in adults. There's many studies that have shown this. This is one of the early ones coming out of Yale. So you can see that there's improvement in depression scores on the hour of hours compared to our traditional antidepressants, where the x-axis is, all the way down the wall, up to 8 weeks to improve symptoms. And this inset is just showing that the time course of depressive symptom relief is separate from that of side effects. So rapid depression improvement, certainly a desirable clinical feature. And then another, this is work from my colleague who just gave his talk, that ketamine is also anti-suicidal in adults, even after you control for its antidepressant effects. And I think that is a particularly important feature for us in child and adolescent psychiatry, where we live with the black box warning, which is still controversial to this day, but I think makes both prescribers and patients and their families nervous. This idea that something that's supposed to treat depression, which is a major risk factor for suicide, that it could, paradoxically have an increase in risk for suicidal thinking. And so ketamine is a compound that's both an antidepressant, but separately anti-suicidal, is very appealing. I'll say one summary slide about mechanism. Jerry did an amazing job yesterday with lots of very fancy cartoons. So this is just my mechanism for dummies slide, I guess. I'm just summarizing that prefrontal cortex and hippocampus are key sites of action. Some of the primary hypotheses are that NMDA antagonism on inhibitory interneurons facilitates glutamate signaling. And then a separate, but I don't think mutually exclusive hypothesis that ketamine metabolites may directly activate AMPA receptors. But just sort of summarizing that ketamine enhances glutamate signaling and promotes synaptic plasticity. So what do we know about ketamine and pediatric pharmacology? Well, we know that there's a lot going on in the brain at this time, particularly in areas that are important for depression, like prefrontal cortex. So there's synaptic pruning of glutamatergic synapses. Animal studies suggest that there's changing relative GABAergic interneuron profiles, and even changes in the receptor subunit compositions of important GABAergic and glutamatergic receptors. So there's a lot of stuff going on. We also take a moment of pause when we think about animal studies that suggest that the risk may be higher for neurotoxic effects of high doses, particularly in the developing brain. So I think these two things make us want to be careful as we're thinking about designing studies in this population. But on the other side of the ledger, preclinical data suggests that ketamine reverses depressive phenotypes in adolescent rats. And then probably more compelling, at least as we were starting this work, is that ketamine has been used safely as an acute anesthetic in pediatrics for quite a long time at this point, and is actually used pretty routinely in the pediatric emergency room. So at least in the acute sense, we feel pretty good about this being a safe treatment to design a study around. So we started a few years ago asking a very simple question. So is a single dose of ketamine safe and effective in adolescents with treatment-resistant depression? We called this the KIDS study. This was funded by the Child Study Center, the American Academy of Child and Adolescent Psychiatry, and the Thrasher Research Fund. And most of this data you can find in our paper that recently came out. So I will tell you about our study subjects. So we were looking for teenagers, so ages 13 to 17 in this study. We were looking for depressed teenagers, so they had to meet DSM-5 criteria for MDD. We wanted significantly depressed adolescents, so they needed to have a children's depression rating scale score of over 40. And we wanted treatment resistance. And so in this study, we defined treatment resistance as remaining depressed despite having at least one prior adequate antidepressant trial, which we defined as greater than 8 weeks at therapeutic dosing, including 4 weeks of stable dosing. As we'll see in a couple slides, the majority of our participants had failed multiple medications, and we had a pretty treatment-resistant sample. And then this was a ketamine in addition to kind of study. So we asked folks to stay on their medication regimen without any changes in agent or dose for the month prior to enrollment, and then during the 4-week trial itself. So who did we not include in this study? So this was an outpatient study. So we actually excluded folks that had suicidal ideation to the degree that it would require an inpatient stay. So an outpatient study, we excluded folks that had a history of psychotic disorder, manic episode, intellectual disability or autism spectrum. We excluded people that had a history of substance dependence, excluding tobacco or nicotine, or anyone that had a positive urine toxicology. We excluded pregnancy, and then anyone that was unable to provide written informed consent. A quick note about controls and blinding. So as you know, placebo rates are pretty high in depression trials, and they're really high in pediatric depression trials. And so we thought it was important to try to use a rigorous control here. So we used midazolam as an active control. And then we put additional measures in place to protect the blind, including having separate efficacy and safety raters. So the folks that were doing the efficacy ratings were at the Child Study Center. This is a nice nighttime picture of the Child Study Center. And then those were separate from the doctors that were doing the safety ratings at the infusion itself, which was done on the hospital research unit at Yale New Haven Hospital. This is the design of the study. It was a randomized midazolam controlled crossover trial. So it's a 4-week study. Infusion days were on day 0 and day 14. This is kind of a zoom in of the infusion day itself. So folks were randomized to get either ketamine at 0.5 milligrams per kilogram over 40 minutes, or midazolam at 0.045 milligrams per kilogram over 40 minutes. They received one compound on day 0 and the alternate compound on day 14. We used the CADS as our side effect rating scale, and then we also took blood work for PK studies in this sample. As you might imagine, we wanted to talk to these kids a lot, so we did rating scales on the days that you see here. And then in a subset, we did some neuroimaging studies as well. So the primary outcome for this short-term study was the MADRS at day 1. So this is taking you through our recruitment. So we assessed 26 participants, 19 consented for the trial. 17 of those 19 went on to receive the first infusion. So 1 withdrew due to an undisclosed medical condition, and 1 basically had a panic attack before we pushed the button for the first infusion and decided to withdraw. So of those that received the first infusion, the investigational drug service randomized 11 to the sequence of midazolam and then ketamine, and 6 to the sequence of ketamine and then midazolam. All of the participants on the left side completed the second infusion, and then 1 participant on the right side withdrew. She improved significantly after the first infusion and decided to go receive ketamine treatment in the community. This is showing some of the subject characteristics. So our sample was predominantly female, consistent with the gender difference in depression incidence that emerges at puberty. Our average age was about 15 and a half. But as you can see in the histogram here, we actually have pretty good representation across the age range that we were targeting. The average BMI was about 26. About half of them were local to Connecticut. You can see from the baseline depression rating scale scores, a 63 on the CDRS and a 33 on the MADRS, that these were pretty significantly depressed folks. The average age of onset for depression was 13 years, and the average duration of the current episode was 21 months. So quite a long sort of chronic course for a lot of these participants. The average number of failed antidepressant trials was 3.2, and this is only including SSRIs, SNRIs, or mirtazapine. Many of these participants had also tried things like antipsychotic augmentation or mood stabilizer treatment. This is just some more data on these participants, so showing that about half had a history of a suicide attempt, 60% with a history of non-suicidal self-injury. And then remember that the participants stayed on their current medication regimens, even though these were ineffective regimens to be in the trial. And so this is showing the medications that people were on during the ketamine treatment. So most people either on an SSRI or SNRI, about 30% receiving antipsychotic augmentation, 1 person on lithium, a couple of mood stabilizers, and then 2 folks that were not on any medication at the time. So this is the primary outcome from the study. So we were looking at day 1 MADRS. So you can see here that ketamine decreases MADRS scores at 1 day following infusion. in this treatment-resistant adolescent population. The effect size here is 0.75, which is pretty similar to what you see in adult studies that are using midazolam as a control. This figure is showing percentage of responders. So we're using kind of the standard definition of response, which is having a greater than 50% decrease from baseline depression scores. So you can see in the green are 5 participants who had a significant response to both ketamine and midazolam, but then 8 people who responded to ketamine only versus 1 responding to midazolam only. That's sort of shown another way here in this box. And I've highlighted, I think, the most important comparison, which is the 8 responding to ketamine and not midazolam versus 1 responding to midazolam and not ketamine. We had 3 participants that did not have a response to either compound. This is the time course data, which was part of our secondary analysis. So this is showing the MADRS across 14 days. And you can see that on average, depression scores remained improved up to 14 days. So that was the last time point that we examined in this short-term study. So encouraging efficacy data, let's talk about side effects. How did people tolerate this treatment? So this is showing the CADs. So you can see this, I feel like the alternate title for the slide is that midazolam isn't the best control, right? So you can see that there's a significant difference in CAD score here, but I think the other take-home point to this slide is that these were transient effects that had dissipated by the second hour. And everyone in our group was able to tolerate these. So no one had to stop the infusion early or to use the emergent diazepam that we have on hand. This is just a list of the most prominent side effects that were reported on the CADs. So these are showing individual CADs items. I've highlighted ones that are similar in both the ketamine group and the midazolam group. So I feel like I have spaced out is something that's reported by participants in both groups. We also see, I feel disconnected from my body, although, you know, that's certainly more prominent in the ketamine group. So again, I think thinking about, is midazolam an appropriate control? There are some similarities to the ketamine experience, but there are certainly some differences. One other area where there are differences are the hemodynamic changes that happen with these compounds. So this is showing in the top panel, systolic and diastolic blood pressure. Here, the asterisks are not showing differences between ketamine and midazolam, but rather are showing significant differences from baseline. So you can see that ketamine raises blood pressure and midazolam decreases blood pressure. On the bottom, you can see that ketamine increases heart rate and doesn't really do anything. Midazolam doesn't really do much with heart rate. I think the critical pieces of information are that, again, people tolerated the treatment very well. We had 4 participants who had blood pressures that met criteria for stage 2 hypertension in adolescence, which is a blood pressure of 140/90, but those pressures resolved. And then none, persisted at the end of the infusion, and nobody had an isolated blood pressure that exceeded 150/95. So no sort of hypertensive urgency or emergency kind of things happened. So I think the single dose conclusions are that ketamine was well tolerated in this population of adolescents, and that ketamine significantly improved depressive symptoms at 1 day post-infusion measured via MADRS in this population. And so I think this preliminary data, and I do consider this small study really preliminary data still, is that ketamine may be safe and effective in the short term, but like adults, it seems that a single dose really has an ephemeral effect. Some of these participants we followed kind of informally afterwards, and everyone ultimately did relapse. And so I think in some ways there's more questions than answers. So we have a lot of work to do, and I'll tell you a little bit about some of the directions that we're taking this work. So one is how to extend the duration of antidepressant action and to better understand maintenance requirements in this population. And then this one, which I think is just so important, maybe it should be like all capital letters, is the safety of repeated dosing in this neurodevelopmental context. Scientifically, I think ketamine also offers itself as a probe to potentially better understand the pathophysiology of adolescent MDD. So I want to talk for a couple of minutes just about considerations around repeated dosing and what information we have about repeated dosing. And so some of the information we have about cumulative ketamine exposures come from studies of folks that are using ketamine recreationally. And from those studies, we see concerns about neurocognitive problems, and also problems with bladder damage or this sort of chronic cystitis that you can see. So that's one sort of imperfect source of information. And another, I think, imperfect source are these animal studies. So animal studies, sometimes using high doses, but other times just doing chronic dosing of sub-anesthetic doses. And these show that in young or even adolescent animals, you can get damage to areas like prefrontal cortex and hippocampus. So things like neuronal cell death and white matter changes. So certainly things that we need to be paying attention to. And the toxicity threshold of repeat ketamine exposure is just not known. And so there's a lot of work that needs to be done in this area. So we have a couple of trials that are about to restart post-COVID or get started up in general. So I'll tell you about those. So the first one we call the SAD Kids trial, which is Severe Adolescent Depression Ketamine Intermediate Duration Study. So we took a long time to come up with this acronym. And this is funded by the Klingenstein Foundation and ACAP. So that's one study that we ran a few participants through pre-COVID and are hopefully getting restarted very soon. And then I just received some funding for a new trial that I'm really excited about. We're calling it the READS trial for reducing adolescent suicidality, safety, efficacy, and connectome phenotypes of IV ketamine. And this is funded through the NIMH. Both trials have kind of a similar structure, which I'll show you. They both start with an acute phase that's sort of a standard parallel design clinical trial where folks are randomized to receive either a paradigm of repeat ketamine or repeat midazolam at the doses that I described in the single dose study. And then after this period of weeks, we break the blind and folks, you can see on the bottom, that received midazolam but did not improve are offered the open ketamine paradigm. And I like this because I think it kind of balances the rigor of having a parallel design double-blind study, but then I also think it's important that we offer active treatment to sick kids who are really struggling. And then in both of these trials, we follow all of the participants over a period of months using standard depression treatment and closely watching their mood, their cognitive function, and some safety measures. So the differences between these two studies, there are some subtle differences. So the first is the population. So at the top, we're sort of repeating the same type of population from the single dose study. So pediatric patients with treatment-resistant depression, here defined as having remained depressed despite having 2 antidepressant trials. In the SAD Kids study, our repeat ketamine paradigm is 6 infusions over 3 weeks. And then there's a limited number of symptom-triggered maintenance infusions. So 2 additional infusions can occur during the open period. A lot of folks say, well, how did you pick 2 over this period of 6 months? And that was actually at the insistence of the FDA, who's concerned about toxicity potential and sort of limited the number of treatments to 8 for adolescent populations in clinical trials, at least at the time that we secured our IND. The primary outcome for this study is a depression outcome, so the Children's Depression Rating Scale. And hopefully we'll be recruiting for that soon. And then the second study, the suicidality study, has a slightly different population. So folks have to meet criteria for treatment-resistant depression, but also need to have a recent suicide event. And so we're really focusing on suicidality in depression in this group. We sort of condensed the dosing paradigm here. So now it's 4 infusions over 2 weeks, and then we're following people for 4 months after that. And the primary outcome is a suicide outcome. So it's the ideation subscale of the Columbia. And so I think this kind of gets at some of the questions that I alluded to when we talked about the black box warning. We're interested in depression outcomes, but we're also interested in suicidality outcomes specifically. So hopefully the next time I talk with you all, we'll have some more information. So I would say I consider the current status of this field, cautious optimism, but I think the unknown risk profile of repeated exposures makes it really hard to feel super confident in our risk-benefit analyses because the risks are just not well defined. And so when folks don't fit within a clinical trial framework, I think patients should be truly treatment resistant. So I can't tell you how many times we've had kids that come in with these, labels in their chart, and then we go back and they've never tried, an 8-week course of Prozac and psychotherapy. And then we recommend that and they get better. And so I think it's important to make sure people have really tried the evidence-based treatments that we do have. Of course, informed consent about risks and benefits and the state of understanding in the field, and then direct supervision by physicians with adequate training, and then having a robust follow-up plan. I'm really excited about Sam's work with coupling CBT to try to extend the duration of wellness. I think a lot of the kids we've seen in our trial have been depressed for so long. It's really important to harness that period of wellness when they can reconnect with friend groups, get synced back up with their schoolwork and all of these things that, felt so insurmountable during the period of depression, and try to kind of regain some of that lost developmental time if possible. And then the last piece, as we have more and more pediatric patients and families that are seeking interventional psychiatric services, which I think of as not just ketamine, but also things like RTMS and ECT, we've heard a wide range of attitudes and practices that people have encountered. And no one has really kind of defined that landscape well, as I know. And so that's something that we're trying to do with a survey study. And actually you all are the type of people that we're hoping to hear from, to try to understand what kind of cases you've seen in your practices, what's the availability of interventional services, the attitudes that people have, and the practice parameters. So it's an anonymous survey. You can win a $50 Amazon gift card. But I think more importantly, it would really help sort of understand the state of the field and help us focus our research efforts on the places where they're needed most. So I will stop there and say thank you to our patients and their families. This is a wonderful population to work with. Our current and past lab managers, the folks on the bottom, Michael Block and Jerry Sanacora, were mentors on the project that I presented. Kevin Kaloris is a pediatric anesthesiologist that helped us with the initial ketamine trial. Natalie is a medical student who is working on the survey project, so she would love for you to take a picture of that QR code and take the survey. She's leaving us for psychiatry residency in a few months and is going to be an amazing psychiatrist. And then also our collaborator, Carlos Zarate, who helped us with the PK studies in the initial trial. So I'm really excited to talk with you all during the discussion section. I know there's going to be a lot to talk about, so I look forward to meeting you then.
Jenny, thank you very much. That's really impressive and very important. So, and I likewise look forward to talking more about that in a little while. But in the meantime, I have the slightly dubious duty of introducing myself because I'm doing the next talk. So I'll just share my screen. No. Let's try that one. Right, can you see that okay?
Yeah, that's all good, Rupert, thank you.
Thanks. Okay, so I'm going to take us up to a little bit before 5, I hope, and I'm going to talk about just a bit of a survey of the regulation of ketamine for psychiatric disorders. I have some disclosures. I've worked on advisory boards and educational work with Janssen, Sage, Lucis, and Allergan. And I run a ketamine clinic. We've seen about 300 patients, I suppose, for private patients and also NHS patients from Oxfordshire. Now, a couple of weeks ago, I had the good fortune to be involved in a workshop at which Paul Applebaum was talking about the ethical challenges of new antidepressants, rapidly acting antidepressants. Now, Paul Applebaum is a psychiatrist from New York, but he's really the doyen of capacity. He practically invented the idea of capacity. And he presented a series of challenges that I thought really nicely summarized the issues. The first one was about the generalizability of trials. Clinical trials are often not generalizable, but there are some specific issues that occur with psychiatric patients. Abuse potential is something we've been talking a bit about, and I'll say a bit more about. And then, of course, he talked about informed consent. And I think that there are a few issues about capacity that we do need to consider. He talked about the ethics of commercialization and the perverse incentives that there can be, and also about the ethics of fair access. And very wisely, I thought, he said, ethical challenges are not a reason to avoid use, but they do require careful attention. And I'd just like to talk about, obviously, ethics. The practical implication of ethics can be of regulation, and that quite often means mandating data collection of some sort or other. So to start with the first one of those, the main issue about generalizability is obviously that one really needs to understand the risk and benefit that the patient sitting in front of you in the real world is at. The ideal way of being able to maximize generalizability would be to have some sort of diagnostic biomarker, so you could really pick out your patient population, but we just don't have those in mental health, and in my view, it's going to be quite a while before we do. At phase 3, one of the key issues about generalizability is, of course, the exclusion criteria that are applied, and companies very obviously apply these, mainly at the behest of the FDA and the regulators, to improve sample homogeneity. But when one excludes patients who are suicidal or have a history of substance misuse or comorbidities, then the results of the trial have rather less applicability to the real world. And of course, if you say that actually these characteristics should be included in one's phase 3 study, then the size and cost of those studies will go up as the sample heterogeneity increases. And that is a barrier to innovation. And I'll talk just a little bit more about sample size and innovation later. So really the bulk of the work on trying to generalize the results of studies comes from comes in phase 4 after licensure in the form of safety studies or open label extensions. And we heard from Carla Canuso yesterday about the SUSTAIN-3 study, the longer term esketamine study. But it's also the case that companies are required in the years after licensure to submit safety data to the regulator on a regular basis. You'll be familiar with the yellow card, or in America, the MedWatch systems, where adverse events are recorded, but not that's all in a responsive way. And then, of course, there are other ways in which one can collect data through surveys of one sort or another. For example, attendance at casualty that Adam referred to, and he also talked about some of this data on the second of Paul Applebaum's challenges, abuse potential. And as Adam said, there are very few dependent addicts, and those who are frequency and dose are obviously the main issues, particularly frequency. We're seeing the rise in ketamine use up, so just over 3% of 16 to 24-year-olds are have used ketamine in the last year. And of those who've used ketamine for recreational or indeed self-treatment, 1 in 5 would like to use less. And ketamine is by and large a pretty safe drug. You can see here from this work from Dave Nutt that they looked at the physical harm and plotted it against, or dependence and plotted against physical harm, and you can see there's a tight correlation between the two. And in this presentation, it just looks as if ketamine falls into roughly the same sort of ballpark as tobacco, alcohol, and benzodiazepines. And that feels about right to me as somebody using it clinically. In terms of this analysis, looks at the overall harms that arise from all sorts of causes of a different range of substances with abuse potential, from alcohol on the left to psilocybin on the right, ketamine pretty much bang in the middle, with the bulk of its harms arising really from its immediate drug-specific sort of impairments. So the harms really not arising there in this analysis primarily from long-term use, from long-term harms, although of course there are the harms of cystitis and so forth. But how does this actually relate to medical use? Well, here the best data on tolerance and on tolerance is really from the SUSTAIN 2 study. This is the 1-year data that's been published. And here in the left-hand panel, what we can see is the MADRS data that has shown a rapid decline in the induction phase, but then the benefit seems to remain pretty constant over the next 11 months. So there's no obvious increase in dose and no obvious worsening of the response over that period. Now, I have to say that doesn't entirely tally with what I see in the ketamine clinic, and there may be all sorts of reasons for that that we can discuss later, but my patients' graphs all look a good deal more stormier than that, if I can put it like that. Maybe I'm doing something wrong. But what I really wanted to say was that there's a distinction between the tolerance to there not being any tolerance to the benefit and there being tolerance to dissociation. Now, this is pretty unusual, I would have thought. And so I think that we have to just keep an open mind about whether this is exactly how things are going to pan out in the real world. Obviously, these patients in the trial, they can't take more than 84 milligrams a week. There are all sorts of restrictions, and if they drop out, they can't come back in. So that obviously is a limitation. And I just want to say that again, in our practice, there are some. This is a bit of confessional, really, but these are the sorts of problems that we see. And we don't see them often, but these are flags that have been taken from the literature relating to opiate misuse. So the sorts of things that we have seen too are having little or scanty information from the previous doctor, where a common thing that we're finding is that people are asking an online doctor to refer to our service. So they're finding somebody who doesn't really know them and then getting a referral. And that probably reflects their frustration and falling out with their existing doctors. We've certainly had people who are uninterested in any alternatives. And if I have said to them, I'm sorry, I can't help you, they say, well, where can I get psilocybin? But they're certainly not interested in having lithium or other neuroleptics. So, I mean, this is a small group. Some have had contact with street drug culture. Some have got current substance misuse when they're referred. And we've had a small number who've tried to find ketamine somewhere else and who have also arrived. I've had some patients who've arrived from America saying that they're taking nasal S-ketamine that's been paid for by the insurance company, and they're also having ketamine top-ups because they regard the dose as being inadequate. And then during the follow-up phase, we've had people who've used higher than the prescribed doses on occasion. That's not very common, but in our practice, we allow patients to, some patients to have oral ketamine at home. And there are some patients who feel much better but ask for more drugs. We've had some patients who've genuinely spilled medication and somewhere one hasn't been quite so sure, and occasionally sort of chaotic and changing stories. And the regulatory sort of implication of this really is that you know, having an experienced mental health team has really been the thing that has helped us to manage some of these things. But taking the drug in the clinic, really having our pharmacy colleagues down on us and checking, like, you know, checking every dot and comma has been really helpful. We also only allow small quantities of drug to be dispensed from the clinic. So there are other regulatory levers that can be pulled. I mean, the most important of which is that ketamine is a Schedule II drug. It's Class B drug, so these scheduling and classes control the possession, supply, procurement, and then how one prescribes it and signs it out in books, that sort of thing. Then alongside that has gone the risk evaluation mitigation strategy. That's the terminology used in the States, and in the UK, the risk minimization plan that goes with Spravato, which means that every dose that's taken has to be logged, and that data is returned to the company. But the company have to pay for that, and they control the data. And this data is not interrogatable. So if I'm prescribing ketamine to somebody, I can't find out for sure whether they're actually taking S-ketamine somewhere else. And it doesn't contain, it doesn't have outcome data attached to it, although obviously Janssen are doing further studies. Now, as far as the informed consent goes, Paul Applebaum refers to perhaps the difficulty in describing non-ordinary experiences, which obviously would undermine one's ability to inform the consent process. There are a variety of resources that one can use for this. And some, obviously, being a professional and able to talk to patients is very important, and there are accredited training programs being run by the ASKP3, including a certification exam. And rather interestingly, the MAPS experiential elective is mandatory for people to qualify as MAPS therapists, and they have to have a personal experience of a facilitated non-ordinary state of consciousness practice. And that usually means some sort of breath work using hyperventilation. And that's a caricature of it, but that's what it involves. And then I want to just briefly touch on the difficult issue of coercion and capacity. What happens when people don't have capacity, and how does that impact on ketamine? So one of the most unpleasant parts of being a psychiatrist is that sometimes one has to put people on a section of the Mental Health Act, and coercion can be part of the issue. Now, Carla Caluso said yesterday that the biggest effect size of ketamine is in the sickest, and I think I can see some truth in that. And obviously, the one thing that we know is that people's attitudes towards their treatment is highly influenced by the context in which it happens, and this inevitably contributes to stigma. And then Paul Applebaum referred to the inability to weigh. So the difficulty in which, so this in the UK, this is capacity is regulated under the Mental Capacity Act and defined as, in this particular item is defined as not understanding the consequences of not having treatment or the risks and benefits. And I mentioned that earlier. But I have certainly met plenty of patients who said something along the lines of, if I could get an hour's relief, I would take it. Now, when somebody says that to me, it sort of suggests to me that they're so desperate that they can't really think. And it's hard for them to think about life beyond depression. They can certainly know what will happen if they don't have ketamine. They understand that, but it's hard to think of what would happen if they do. That this is all slightly different from the psychiatric emergency issue, but obviously the inability to weigh is likely to manifest significantly in psychiatric emergencies, such as are envisaged in the label for the new label for the for Spravato. So this is the short-term treatment for rapid reduction of depressive symptoms, and so therefore it's rather inevitable that one's going to be treating people with ketamine who lack capacity. That's different from saying that they're not wanting to have the treatment. But I think that this is something that we need to consider. And then to Paul Applebaum's ethical dilemma about commercialization, I have feet in both camps in that I have worked, both have a private patients come as well as the NHS, as I mentioned at the beginning. And about half of the referrals that get made to us, I don't end up seeing for an assessment. Often the diagnosis of treatment-resistant depression seems to have been distorted to fit the available treatment. But in my entire professional life, the only complaints, the formal complaints that I've ever had have been relating to people who I declined to treat with ketamine. So it's, I think the other things that I notice are that people in private practice it's easier to stop the drug if it's not working because people don't want to pay for it anymore. And we outsource the psychotherapy, whereas patients who come into the NHS, they tend to require more, they have more frequent clinic visits. So there's obviously cost implications there. And then I'd just like to finish up a bit, or the final challenge was of fair access. And in the UK, this is effectively effected through NICE, the National Institute for Clinical Excellence. They are, in fact, it's not the MHRA, it's not the initial people awarding the license that regulate access, it's NICE and the insurers in the US. Just for those of you who don't know, the NICE timetable for considering esketamine for treatment-resistant depression has actually had 3 rounds of consultation. That's a bit unusual. The last meeting was on the 11th of February and the decision is still awaited. That length of time is also a bit unusual. And part of the reason for that will be that there's a confidential negotiation on price that goes on. And this NICE regulates in England, Wales, and Northern Ireland, whereas the Scots have their own medicines consortium. And the Scots have, Scottish Medicine Consortium has said that Spravato should be available on the NHS. But unlike with NICE in Scotland, that isn't a mandate. It doesn't have to be made available by the NHS. It's guidance. Whereas for NICE, if they recommend it, then people have, then the local commissioning authorities have to pay for it. And these are the sorts of costs that are involved. So Spravato, its UK list price, and as I mentioned, that's not necessarily the NHS price, is about it's £489 per dose for 84 milligrams. And remember this, you start with twice weekly for a month, and then usually once a week or once a fortnight. And on that basis, the company has generated an assumed 12-month cost of £10,000 per trial. And that has resulted in a company analysis of the cost of per quality of £7,000. The draft NICE guide estimate of this was £55,000 to £62,000 per quality, and you have to get under 30,000 for it to be acceptable to NICE. So either the price will have to come down significantly, or something else will have to give, or it won't be made available in the NHS. The contrast here is with ketamine. So we typically get up to about 6 or 7 treatments out of one of these £8 vials. And ketamine, S-ketamine is not itself it is itself a generic drug. So it's the mode of administration that's been licensed to Janssen. So one of the key things for NICE is that their data demands are different to those that are required for licensure. So, for example, they're particularly interested in whether the population being treated in the NHS is different to that in the trials. And this comes back to our generalizability issue. For example, might the NHS patients be more treatment resistant? Now, of course, what Carla told us yesterday was that the more treatment resistant patients actually do better than the patients who are less treatment resistant. That's obviously important, but it's not there in the initial data. It's absolutely crucial to know how long the average course is, how long the average person will take this before stopping it. Whether and in the modeling, it's very important to know whether the trials are, whether the ketamine is, whether the depression is episodic or not. We need to know what happens after treatment. So the lack of these data actually reduce access. So getting these data is really important. And I was delighted to see that in this recent the Department of Health white paper that's been put before Parliament, published recently, right at the very end of it, had a little section saying we think that the MHRA ought to be able to mandate publicly funded registries that can include outcomes. And of course, if that could include off-label drugs, and it could include all rapidly acting drugs for affective disorders, and if it could be interrogatable, then this would be a great way of supporting early access schemes for rapid antidepressants. But it opens a further ethical issue. Should we be introducing in an early phase of real world use the idea that unless the patient contributes data, then they can't have a drug, because obviously we need to know what their symptoms are. So just to summarize, regulation often requires a data element to it. There's a wide range of regulation already in place, but we really need better data to support fair access, to compensate for poor generalizability, and ultimately we need it to reassure everybody. And the main issue here is stewardship of the drug. It would just be such a shame if our lack of data and lack of control on the drugs, particularly of unlicensed ketamine, resulted in further stigma and restrictions. So this is best to happen in phase 4, and I'm hoping that new legislation might just do the trick. I've gone slightly over my time, and I apologize for that, but thank you for your attention. So we are going to start on time with the next session, which I think is going to be in just about 5 minutes' time. So do join us then. As I mentioned right at the beginning of today, in fact, what we're going to do, because Adam is unable to stay for the whole session, is we're going to have all speakers in the same session, and you don't need to go to a breakout room, so don't go looking for one. Just stay exactly where you are, and then we'll have a panel of all today's speakers. And then towards the end of the session, and we've got as much as an hour and a half if we need it, we will address your questions. We will explain the answers to your questions that have been given to us by Paul Glue, who did a talk on ketamine and anxiety disorders yesterday, and Saiying Wang, whose talk on postpartum depression you heard a bit earlier. So look forward to seeing you in those sessions in now just a very few minutes. Thank you.